Hello everyone. Today we are going to be discussing about an important topic in neurology known as Brown-sequard syndrome. So this is very important. In the last video we have discussed about syringomyelia. So now we are going to be discussing about Brown-sequard syndrome. But before we go into the topic, let us discuss in a nutshell the basic anatomy and physiology of the neurology and this pathway, so that to understand the Brown-sequard syndrome. So as we have already know that this is the dorsal horn of the spinal cord. This is the ventral horn. That is, you can say this is posterior, this is anterior. This is on the right side. This is on the left side. This is dorsal horn. This is also ventral horn. So this in this dorsal horn, it is through it where any sensation, be it vibration, be it pain, be it temperature sensation, all sensory input, they have to go through this posterior. That's from this right side, they have to go through this dorsal horn. If it is from the left side, then they have to go through this left dorsal horn. If it is motor activation, that's the motor pathway, that's motor nerves, they have to pass through the anterior for the left side, then for the right side, this side for the right side. So that is it. So for example, let's say there is a fibers for taking vibration and then proprioception. We have already know that fibers that are taking vibration and proprioception, they are passing through the same pathway, which is called dorsal column medial lemniscus system. So they pass through, when they come through the dorsal horn, they pass to the posterior aspect. This is to the side. Fibers that are carrying vibration, and then fibers that are actually carrying proprioception. So that is it. And then from the left side, fibers that are carrying also vibration, and then what? And then proprioception, they also go through this side. So that's it. So these fibers, they cross at the level of medulla oblongata, a little bit above the level of medulla oblongata. That is in a nutshell, in the brainstem, they cross to the opposite side, so that to end in the opposite thalamus. For example, these fibers from the left side, they end at the right thalamus, and then these fibers from the right side, they end at the left thalamus, and then eventually they end at the contralateral hemispheres, right? So that is it. So while fibers for temperature and pain, they also pass through this dorsal horn, because they are also sensory input, right? But the moment they enter the spinal cord, they go to the opposite side. Unlike this, they cross at the level of brainstem, but this they cross right away, they enter the spinal cord. So also fibers from the left side, they also come here, and then they go up. Fibers that are taking pain and temperature, then the moment they enter the spinal cord, then they cross and then go up, right? So that is it. Fibers from right side, they come here and then they cross and then go. Fibers from left side, they come through this, then they cross. So that is, they cross at the level of the spinal cord, not at the level of brainstem, right? So this is very crucial in understanding the pathophysiology of Brown-sequard syndrome, actually. So that is it. So let's say this is it. So we divide this into half. The Brown-sequard syndrome, it is a kind of syndrome that is affecting half, that is hemi section of the spinal cord. It is affecting half of the spinal cord, actually, right? So let's say this side it is affected. In Brown-sequard syndrome, this side is affected, actually. So as we can see, fibers of the same side that are taking vibration and then proprioception, they are damaged, right? While fibers of the opposite side that are taking temperature and then pain, they are also damaged, right? So this is very important as for understanding the presentation of Brown-sequard syndrome, right? So that is it. So by definition, actually, Brown-sequard syndrome can be defined as the syndrome where there is damage to the hemi, that's half of spinal cord section. spinal cord section with an unaffected half. So that is it. So now this, I draw the spinal cord like this into different segments. This is, for example, first segment, second segment, third segment, fourth segment. We have so many segments. So let's say this, the middle one, it is the one that is affected actually. So let us color this. This side it is affected, and we have already know that we have upper motor neuron and then we have lower motor neurons. So that is it. This is the upper motor neurons that are directly from the cerebral cortex, and these are the lower motor neurons that are directly on the muscles or on the target gland. So they are the one that are stimulating the muscle actually. So this upper motor neuron, it is the one that is signal it is sent. The signal is sent through it and then activate this lower motor neuron, then to produce a meningeal movement. Without this upper motor neuron, this lower motor neuron can still activate this muscle, but not in a meningeal manner. It is going to produce a meningealess movement, right? So that is it, because it is not activated from the cerebral cortex. But if, for example, you intend to move your hand, then there have to be a signal from the cerebral cortex, right, through this upper motor neuron, then to this lower motor neuron, then there will be a kind of meningeal and voluntary movement, right? But if this is damaged, this will still activate the muscle, but in a kind of involuntary, right, spastic paralysis. That's called spastic paralysis. So that is it. So now let us actually dive into the topic. So etiology. What will actually cause this half of the spinal cord, this half, to get damaged, leaving the other half? The most important etiologic factor is actually kind of stabbing knife at the back. Stabbing knife at the back. For example, when someone stab you at the back, and then with knife actually, then this will actually comes through this and puncture this area and then damage this half of it. But this upper part is unaffected. This upper lower segment is also unaffected actually. So that is it. But don't forget that there are some upper motor neurons that pass through this, right? So some they relay their synapse with the lower motor neuron at this level, while some they go down and then they relay their lower motor neuron at this level, while some they even stay at this side to connect with their lower motor neurons. So that is it. So let's say it is where this knife hit actually. This segment will going to be damaged, while this side is not going to be affected, right? Or another one is actually a gunshot. If it pass and then affect this half, right? So that is it. And then the rare causes are called, for example, spinal cord tumor, or TB. When TB metastasizes, that's when TB spread to the region. So that is it. So now let us see the symptom, or to say the presentation actually. How do this Brown-sequard syndrome present? Actually, the signs and symptoms of the signs and symptoms of Brown-sequard syndrome actually there are going to be a kind of ipsilateral, that is the some side, ipsilateral spastic paralysis below the lesion, below the level of the lesion right? And then placid paralysis, and then placid paralysis at the level of the lesion. So what I actually meant here is, when there will going to be spastic paralysis and then placid paralysis at the same side. This is called ipsilateral, that means at the same side. If this half of the spinal cord, it is the right side, if it is, for example, it is the right half of the spinal cord that is get damaged, so there will going to be a kind of right side spastic paralysis and then right side placid paralysis. So why? Because where are we going to have spastic paralysis? Below the level of the lesion, because as we have already know that, let us see, these are some upper motor neurons that are passing through this. For example, let's say to supply muscle, that is, for example, let's say at this side, like this. So these upper motor neurons are going they have to pass through this damaged area, right? So they pass through this and then they relay their synapse with their lower motor neuron, right? So if this is get damaged, together with this upper motor neuron are going to be damaged, right? If they are going to be damaged, then this at the lower level of the damage, the lower motor neuron will not going to be inactivated when movement is not needed, right? So this lower motor neuron will going to continuously activate this muscle, because the upper motor neuron that is actually modifying it get damaged, because they have to pass through the damage, right? So that is why the person will have spastic paralysis. While at the level of the lesion, we also have lower motor neuron at this level. For example, let's say we have another muscle here that are supplied by this lower motor neuron. So this at this level, actually their upper motor neuron are okay, but their lower motor neuron get involved in this accident, then definitely the lower motor neuron, despite the upper motor neuron is normal, then the lower motor neuron is damaged. Despite normal upper motor neuron, then definitely this muscle will going to be weakened. But now it will going to be placid, not spastic, right? So that is it. So I hope you understand the pathophysiology actually. So this is why we will have this presentation. And then we have a kind of contralateral loss of temperature. As we have already seen, temperature and pain sensation, they used to cross since at the beginning of the enter into the spinal cord, right? So definitely the moment they enter the spinal cord, they cross to the opposite side, right? So there will going to be a kind of contralateral, that is opposite side, contralateral loss of temperature and the pain sensation. So when we say contralateral, means, for example, if it is right side of the spinal cord that is affected, then there will going to be loss of temperature and pain sensation in the left side of the body, right? Because we have already know that in the beginning of the video, the fibers that are carrying temperature and pain sensation, they cross since at the level of the spinal cord, right? So, for example, like this, the moment they enter the spinal cord, then they cross like this. That is the fibers that are carrying temperature and pain. Let's say from the left side, this is from the right side. The moment they enter, then they cross. So if this here is damaged, the fibers that are coming from the right side carrying pain and temperature, they also get damaged, right? So that's why the person will going to have loss of temperature and then pain sensation in the right side, despite it is the left side that get damaged, right? So that is it. So we have another symptom actually. Another symptom, this is not even a symptom, is a kind of sign called Babinski sign. Babinski's sign. This Babinski sign is actually seen when there is damage to the upper motor neuron. So this Babinski sign, it will going to be damage to the upper motor neuron. So upper motor neuron are going to be damaged in the level that are actually below the lesion, right? That is we are going to have a kind of positive Babinski sign. So that is it. So when we see that is in ipsilateral, because here in ipsilateral we have symptom of spastic paralysis, and spastic paralysis is a symptom of actually upper motor neuron damage. So that's why we are going to have also another symptom of, or another sign of upper motor neuron damage in the ipsilateral side. And then this Babinski sign is a classical sign of upper motor neuron damage, right? But it is normally in infant. Yeah, it is normal in infant, because infant, they didn't have well developed upper motor neurons. So that is it. So now we are going to see the diagnosis, how you will diagnose this. Actually, it depends on the history of the patient. If, for example, the patient has a history of TB, then maybe you will be suspecting TB. It is the one that caused the disease, the Brown-sequard syndrome. And then if the person is stabbed with a knife, that one is actually obvious, right? So that is it. Then the diagnosis, but for you to diagnose this, actually, if you are maybe suspecting tumor or whatsoever, then you can use MRI. MRI is a good imaging modality to locate tumor, right? If you are suspecting tumor to be the causative agent. So then treatment. Also treatment depend on the cause, but sometimes they said high dose of steroid, have effect actually. High dose of steroid is effective sometimes. So that is it. So thank you very much. I hope you understand. Thank you.